I would like to introduce the last speaker, the last but not the least, who the last speaker was talking from a project from the US, this one from South Africa. This one takes us to Europe. And our last speaker is Sarah Crossford, who is going to talk to us about mortality and causes of death among women living with HIV in the United Kingdom. Sarah Croxford is an HIV STI prevention scientist leading on the surveillance of new HIV and AIDS diagnosis and deaths in the United Kingdom at Public Health England. Sarah.
Thanks very much. Hello, everyone. I'd like to thank the conference organizers for having me here. As Carol said, my name is Sarah Croxford. I'm an HIV scientist for the Centre of Infectious Disease Surveillance and Control in the UK. And today I'm going to be presenting some new analyses looking at causes of death among women living with HIV in the UK. So before I begin, I want to highlight some of our key findings. So firstly, and most importantly, is the fact that we found that in the era of effective treatment, AIDS is still the most common cause of death among HIV-positive women diagnosed since 1997 in the UK. And this is due in large part to high rates of late diagnosis. Secondly, that classification of causes of death can be challenging, and particularly disentangling AIDS and non-AIDS causes. And finally, we had high rates of non-AIDS deaths in our cohort, which we'd like to explore further. So to give some context to our analyses, here you can see the HIV epidemic in the UK, which has been monitored by Public Health England and its predecessors since the first AIDS notification in 1981. In the early years, the epidemic was largely concentrated among men who have sex with men, MSM, with large increases in diagnoses among men and women from sub-Saharan Africa from the late 1990s. We can also see in this graph the drastic declines in AIDS and deaths since the introduction of effective treatment in the mid-1990s. And despite this decline, we still see about 500 deaths among people living with HIV each year in the UK, and about 2/3 of these are dying within their first year of diagnoses. So we recently published 10-year all-cause mortality trends among people living with HIV aged 15 to 59 years. So similar to most high-income countries, death rates among HIV-positive persons in the UK have dramatically declined since the introduction of treatment. However, the all-cause mortality rate was still 5 times higher than that of the general population in 2012. We see mortality rates are similar among men and women, with highest mortality among people who inject drugs and those of older age groups. So the objectives of our study and further work we wanted to do was firstly to explore survival among the cohort of women diagnosed with HIV since 1997 after the introduction of treatment. And secondly, we wanted to describe AIDS and non-AIDS causes of death among this group. So what do we know about women living with HIV in the UK? So by the end of 2012, there were nearly 32,000 women living with HIV, with about 7,700 who are unaware of their infection. As you can see from the graph on the right, late diagnosis among women is high and has remained high over the last decade, with about 57% of all women diagnosed late in 2012. And this is despite the fact that in the UK we have a high uptake of a universal antenatal screening program. The majority of women are diagnosed with HIV in STI clinics, with about 1/5 diagnosed in antenatal settings. And we really wanted to focus our analysis on women, as this is a population that is often understudied in the UK. A lot of our prevention work is focused on men who have sex with men, which is the group most affected. So if we go into our methods, our study comprised of a national cohort of adult women diagnosed with HIV and seen for HIV care in England and Wales between 1997 and 2012. This cohort is comprehensive and the clinical data is updated annually. And we routinely match this data to our vital statistics data from the Office of National Statistics to get our death records. So what we did is we looked at deaths to the end of 2012, and we categorized these using a modified code protocol into AIDS and non-AIDS related causes. Each death was independently reviewed by an epidemiologist and a clinician, and in areas of disagreement, in cases of disagreement, we would go for third-party adjudication with a clinical consultant and also the lead of HIV surveillance in the UK. We also performed a survival analysis, and we censored individuals by date of death or date last seen for HIV care. So this is our cohort of women. We see 32,400 women diagnosed in England and Wales between 1997 and 2012. We excluded about 2,400 from our analyses. This is because they had initial HIV diagnoses but never were seen in care. So this leaves us with 30,000 people in our cohort. And this gives us about 161,000 person years. The majority of these individuals were infected through heterosexual sex, were of Black African ethnicity, and diagnosed under the age of 35. And we see about 5.2% of the women included died, and this is 1,575 deaths, giving us an all-cause mortality rate of 9.8 per 1,000 years. And if we crudely compare this to the general population, this is about 6 times higher than the general population aged 15 to 64. So if we look at survival of our cohort, we used Kaplan-Meier curves to plot survival over time by CD4 count at diagnosis. As you can see in the left-hand graph, women's survival probability overall is high, 95% after 5 years and 90% after 15 years. Furthermore, women consistently have higher survival probability than men, especially at lower counts as shown on the right. And not surprisingly, overall, we're seeing poorer survival among those that were diagnosed with low CD4 counts. If we look at those patients that died, so here we're looking at women, we see that women were diagnosed median age of 37 and a median age of death of 40, with about 75 women dying over the age of 65. The majority of our population is Black African heterosexuals, with a median survival post-diagnosis of 4.6 months, and we see about 80% of this population were diagnosed late, with only 47% ever receiving treatment. If we compare this to men, we see men were diagnosed at later ages, so median age of diagnosis of 42 and 44. We see that these individuals had longer survival post-diagnosis and a lower proportion diagnosed late. And we think this is because the majority of our male population were white men who have sex with men, who in the UK are known to be frequent testers and have low rates of late diagnosis of 37% in 2012. So if we break down those that died by cause of death, so here we're looking at women, we see the greatest number of women died of AIDS and non-AIDS infections, and we were unable to classify 149 cases. If we compare the distribution to men, we see it's quite similar. However, women, a higher proportion of women significantly died of AIDS and non-AIDS infections, where significantly lower proportion died of cardiovascular disease and stroke, liver diseases, accident, suicide, and substance abuse. If we compare those that died of AIDS versus non-AIDS, we see the 3 most common causes of death among those dying of AIDS is pneumocystis, lymphomas, tuberculosis or mycobacterium infection. Not surprisingly, 90% of this population that died of AIDS were diagnosed late, with a low median age of death and a short median survival. If we compare this to non-AIDS, we see higher median age of death and longer survival, and 72% diagnosed late. And we see that the rate, the mortality rate here was about 3 times that of those dying of non-AIDS in the general population, age 15 to 64. So if we break down non-AIDS causes, most women died of non-AIDS infections. The most common causes were unspecified or non-recurrent pneumonia and sepsis. And we see about 79% of this population diagnosed late, which leads us to believe there may be some misclassification, and we're missing some AIDS cases. If we look at our non-AIDS malignancies, the most common were breast cancer and lung cancer. Median age of death was 44. Cardiovascular disease and stroke. So in the area of treatment, and as people are living longer with HIV, comorbidities are particularly important. We see 52% of these 89 died of stroke and 29% of other cardiovascular causes. My colleague Aileen Kitching presented a poster on Monday. I'm not sure if any of you had a chance to go and see it, but it's looking at deaths due to viral hepatitis and other causes of liver disease. Key findings were that progression to complications of viral hepatitis accounted for 1/3 of all liver deaths among women, and 1/3 were due to alcoholic liver disease. And we see about 1/5 of these were infected through injecting drug use. Accident and suicide and substance abuse accounted for 33 deaths overall in our cohort. Among those dying of substance abuse, we see 58% of all deaths were among people with HIV infected through injecting drug use. We see low median age of death in both groups. And finally, other causes. This just captures all the other code causes. So we've got chronic obstructive pulmonary disease, renal failure, pancreatitis, gastrointestinal hemorrhage, etc. So we've got the cohort of people living with HIV in the UK and accessing care of women. So what do we think are potential challenges and limitations to our study? So firstly, as deaths were coded retrospectively, there's a chance we misclassified AIDS versus non-AIDS deaths due to incomplete clinical information. Secondly, our analysis focuses on women diagnosed since 1997. So we're not seeing all deaths post-introduction of treatment. We're missing those that were diagnosed pre-HAART and died post-HAART. Thirdly, in the UK, we do not collect patient names or health system numbers as part of routine HIV surveillance. So we rely on the strict matching algorithm to match this data to our vital statistics register. And while we may be missing a few deaths because of this, we don't think this has impacted significantly on our analysis. In terms of current and future work and where we need to go from here, we think it's quite important that we calculate age-standardized mortality rates to better compare to the general population. And we are working with local pathologists to review and audit cases where it was difficult to assign a cause of death in a London death audit. We hope to use this information to improve patient pathways and quality of care and reduce preventable death. So, in conclusion, despite high uptake of the antenatal screening program, there are high rates of late diagnosis and deaths among HIV-positive women in the UK. The fact that AIDS, a preventable cause, is still the most common cause of death is unacceptable in a time of effective treatment, and in the UK, free treatment and free HIV care. Our findings highlight the need to increase and expand HIV testing into non-traditional settings, and highlight that good surveillance data on deaths and causes of death is crucial in monitoring the response to the HIV epidemic. And no one should be dying of AIDS in 2014. Thank you very much. I would also like to acknowledge our collaborators contributing to HIV surveillance in the UK. Without their generosity, time, and effort, the current level of understanding of the epidemic could not have been obtained.
Thank you very much, Sarah. That was another very powerful presentation. So now we have a little pile of questions here, which Carol is very kindly going to go through quickly. I have to say, coming from the UK myself, I'm particularly struck by what Sarah was describing. I mean, it's just fascinating, isn't it, and awful that actually 1/3 of people living with HIV in the UK now are women, and yet people still say to us in the UK, oh, I didn't know women could get HIV. And I think this is something which is really powerful, which has come out for us very clearly again in this conference, and is highlighted by all the presentations on this session, is that of course, key populations are critical, but actually the gender analysis of what's going on within key populations is really missing. And I think that's why all of the research which has been presented in this session is so important and really deserves a very wide readership, because I think in every continent, in every country, we need to be doing the kind of research that the presenters here this morning have been doing. So thank you all so much.